Intracapsular hip fractures, blood supply is important. The major blood supply is medial circumflex femoral artery. The second most is lateral circumflex femoral artery. These arteries make an capsular arterial ring, goes up. The lateral epiphyseal artery is an important artery, makes an intracapsular arterial ring, and supplies the head. There is metaphyseal diaphyseal blood supply, and the artery through ligamentum teres, which does reduces with the passage of time. Medial circumflex femoral artery at risk while doing iliopsoas stenotomy courses around the iliopsoas and pectineus. Less than 4, all the 3 arteries give the good blood supply. 4 to 10, metaphyseal blood supply from the extracapsular arterial ring, ascending cervical artery, and subsynovial arterial ring. Epiphyseal artery and medial epiphyseal artery from ligament teres, but still do not develop enough between 4 to 10 years to provide blood supply to prevent AVN. Associated injuries, femoral shaft fractures, and femoral neck fractures is important correlation, 5 to 10% of incidents. Most of them are undisplaced. When clinically suspected hip fractures but X-ray not conclusive, you can request MRI. This is BUA guidelines. If young patient, ask for full-length femur X-ray. Guideline classification is important. Type 1 is incomplete valgus, type 2 is complete, type 3 is complete but partially displaced, and type 4 is complete, fully displaced. Powell classification is important. Horizontal line 30, 30 to 50, more than 50. Shear forces are increasing when Powell classification level is increasing. Nice guidelines. Patient should be nursed on an air mattress. Protein and mineral supplementation. Do not delay if patient is on antiplatelet therapy, and G is recommended if on dual therapy. Hip guidelines. These are the Blue Book guidelines, standard of care for fragility fractures, and National Hip Fracture Database. Any patient should have MTT, anti-resorptive therapy, MRI if needed, analgesia, comorbidities, AMTS, VTE prophylaxis, and these details should be documented. Regarding the Blue Book advices and the NICE advices. 1. Admit within 4 hours in orthopedic department. MRI if negative X-rays. If MRI is not available, you can do a CT scan. Number 3, surgery within 36 hours if medically fit. Number 4, pain optimization by multimodal strategy. Fascia iliaca block can be given. Number 5, offer choice of spinal or general anesthesia or intraoperative nerve blocks. Number 6, surgery which can start full weight bearing in immediate post-operative period. Number 6, arthroplasty in patient with displaced fractures. Number 8, consider full hip replacement in displaced intracapsular fractures who are able to walk independently. Number 9, anterolateral approach in favor of posterior approach in hemiarthroplasty. Number 10, extramedullary implant such as sliding hip screw in preference of intermediate nail in trochanteric fractures above including the lesser trochanter. Number 10, use intermediate nail if there is a subtrochanteric fracture. Number 11, physiotherapy mobilization on a day or after the surgery. Number 12, orthogeriatric assessment. Number 13, terminally ill MDT should be placed for a palliative approach. Number 12, care should minimize the delirium. Number 13, discharge in medically fit and has mental ability to participate in rehab and can mobilize short distances.